Hello and welcome to our session on hypersensitive disorder in pregnancy. Today we have Dr. Swathi Gogineni among us to educate us on the topic, and she is going to be enlightening us on the topic at hand. We are so pleased to have her as a guest. Ma'am, you have the stage.
Yeah, thank you. I'm Dr. Swathi Gogineni. I'm a consultant obstetrician and gynecologist at Apollo Cradle, Jubilee Hills. So I'm here to discuss about hypertensive disorders in pregnancy. So first and foremost, what is hypertension? So whenever the blood pressure is more than normal, it is called hypertension. Now coming to the scenario of hypertension in pregnancy, we can broadly classify patients into two types. Either it can be chronic hypertension or it can be hypertension specific to pregnancy. So chronic hypertension is when the woman is a hypertensive even before conception. So she knows that she's a hypertensive and the blood pressure continues even during pregnancy also. So that is called chronic hypertension. Apart from this, there are some specific conditions which are specific to pregnancy per se. That is, they develop only during pregnancy. So these are the two broad categories in pregnancy. So coming to the conditions specific in pregnancy, again there are two types. Either we have gestational hypertension or we have something called as pre-eclampsia. So gestational hypertension is when the hypertension develops for the first time only during pregnancy. And this usually happens after 20 weeks of gestation. So this is called as gestational hypertension. So apart from the high blood pressure, she usually doesn't have the protein loss in her urine. Supposing in addition to the high blood pressure, if she also has protein loss in the urine, then there is something called as pre-eclampsia. So this gestational hypertension and pre-eclampsia are conditions which are specific to pregnancy. That is, they start during pregnancy. But chronic hypertension is where the woman is already a known hypertensive. It's been there for quite some time before conception and it continues even during pregnancy also. So now we need to know what are the risk factors. Now, why is she developing this hypertension? So again, I want to broadly classify, like when you come to chronic hypertension, so why is she already a hypertensive? See, most of these women are in their, say, 20s or 30s, but why have they already developed hypertension? So there are numerous reasons. So it can be related, to some cardiac conditions or more commonly some renal conditions. So renal conditions, renovascular we say. So whenever the kidneys and, the blood vessels are involved, that actually leads to high blood pressure. So the common reasons are cardiac conditions, renal, vascular conditions. There are certain conditions called vasculitis or, autoimmune conditions where the woman is actually developing high blood pressure. Or sometimes because of a very strong family history. Okay, or if the woman is extremely obese or she has any other known medical issues, they all can lead to this chronic hypertension. And more so our race, even the ethnic origin also determines whether there is increased risk of hypertension or not. So it actually puts Indians at high risk of hypertension. In addition to this, as I told you, family history, weight, sometimes, even the age, like, elderly women, like, those who don't conceive, like say till they're 38, 39, 40, they might actually develop hypertension after the age of 35. So all these are risk factors for chronic hypertension. Now, in addition to this, as I told you, the specific conditions like in pregnancy, you have this gestational hypertension or pre-eclampsia. So what are the risk factors for those conditions? So here again, see, there are actually extremes of age group. It can be like, teenage pregnancies, like, very early, 18, 19, 20, and, very short marital life. Like, they've had intercourse for a very short time, like, in the first month or second month itself, they conceive. So studies have shown that whenever there is a very limited and short exposure to the sperms, that also can increase their risk of developing hypertension. And the other extreme, like again, elderly primigravidas, nowadays, because of educational, pressures or the financial pressures, late marriage, late childbearing. So we come across many primigravidas who are like, above 35 years of age. So the age itself puts them at a risk of developing high blood pressure. And in addition, again, obesity, the poor lifestyle to blame. So it actually puts them at a high risk of developing gestational hypertension, gestational diabetes, and other medical disorders in pregnancy. And in addition, again, the race, as I told you, a very strong family history, I told you. And if she has had a gestational hypertension in the previous pregnancies, so that itself is again a risk factor for developing blood pressure in the current pregnancy. And if she has certain other conditions like, vasculitis or any renal conditions, so she might not have had blood pressure before pregnancy, but she might be a known a patient of those disorders. So they actually put her at an increased risk of developing high blood pressure during this pregnancy, like a known cardiac disorder or a known renal disorder or a known vasculitis condition or a known autoimmune condition, or there is something called the antiphospholipid antibody syndrome. So such medical conditions actually increase the risk of, the woman developing high blood pressure during pregnancy. So now coming to the topic, so this is broadly about the etiology, so why it actually happens. So now coming to how do we manage. So now we have a patient in front of us. Of course, we do blood pressure recording in each of the antenatal visits. So people who are chronic hypertensives, if they know it, yes, they will tell you the history and then we know it in the first visit itself. But sometimes they might be chronic hypertensives and they might not be knowing it. So when she actually comes to you for an early checkup and you record the blood pressure and it is high, that is when we know that she's a chronic hypertensive, and then we have to go into the investigations where we evaluate her cardiac, renal, and other vascular conditions. We have to take a physician opinion, a cardiologist or a nephrologist opinion, depending on whatever is the etiology. Now, apart from this, the gestational hypertension or pre-eclampsia usually develop after the 20th week. So the initial visit and all, the blood pressure will most likely be normal. And after the 20 weeks onwards, we actually see that, the blood pressure starts going high. And so how high is actually called as high? So we know that, 120 over 80 or 110 over 70 is normal, but it is not just one number. So whenever the blood pressure is more than 140 by 90 millimeters of mercury, that is the systolic blood pressure, if it is more than 140 and the diastolic is more than 90, and it's not just on one occasion, but on two occasions, at least 4 hours apart, 4 to 6 hours apart, that is when we actually say that the blood pressure is high. So when we come across a patient, like in our OPD, we see that the blood pressure is high. Okay, maybe the stress, strain, she might be tensed up. So we give her some time and then we recheck the blood pressure after some time. Now, supposing even the second reading is also high, that is when actually we label her as a gestational hypertension case. And then we also have to check her albumin loss in the urine. So like as I told you, there are two entities. You have gestational hypertension and you have pre-eclampsia. So the main discriminating factor between both of these is the albumin loss in the urine. So where the protein loss is there, like, we normally do the dipsticks where we check for albumin in the urine, and we also have the 24 hours albumin excretion. So where it is more than 300 milligrams in 24 hours. Okay, so that is when we actually call her as a case of pre-eclampsia. But where she's actually not losing her, albumin in the urine, and it's only the high blood pressure recordings, she's a case of gestational hypertension. And certain other medical issues, like, even the thyroid disorders, then multiple pregnancy, pregnancy per se, they actually increase the risk of her developing hypertension. Now, why are we so concerned about the hypertension, be it chronic hypertension or gestational hypertension or preeclampsia? Why are we concerned? The reason being, yes, if it is not controlled, if it is not managed well, it can result in a number of complications. And complications can again be the maternal complications or they can be the fetal complications. And the maternal complications, so once the blood pressure is high, so supposing, see, it can the pre-existing condition, like supposing she has a known cardiac condition or a renal condition, they might actually worsen. So we have to keep monitoring those conditions also during pregnancy. It must be a multidisciplinary approach where we involve even that team also. Otherwise, per se, if it's a gestational hypertension or a case of preeclampsia, so we are mainly concerned about certain medical, that is maternal complications as well as the fetal. So coming to the maternal complications, she's at a risk of throwing a fit. So medically, it is called as eclampsia. So preeclampsia is, where the blood pressure is high along with the protein loss. In addition to this, if she has high blood pressure and then she throws a fit, it is called as eclampsia. So this eclampsia, that is the fit she can throw in the antenatal period. It is called as antepartum eclampsia, or she can throw the fit during labor, then it is called as intrapartum eclampsia, or even she can throw a fit after delivery also, it is called as postpartum eclampsia. In addition to this, there is another deadly condition called as abruption. See, normally we know that, the placenta is actually the, the organ that supplies blood, nutrition to the baby. And separation of placenta happens only after the baby's delivery, be it normal delivery or cesarean section. But in cases of high blood pressure, sometimes there can be a premature separation of placenta, where even without delivery of the baby, the placenta has separated from its bed. And then, suddenly there is a lot of bleeding happening that collects between the placenta and the uterine wall. So what happens when the placenta separates? So when it separates, the blood supply, the oxygen is not going properly to the baby. So that can actually result in an intrauterine fetal death, a very deadly thing. It can happen anytime during pregnancy. So when the blood pressure is not well controlled, sometimes even mild pre-eclampsia cases, we see landing up in abruption. So all cases of high blood pressure recording, we do counsel them regarding their risk of throwing a fit called eclampsia or abruption, or they can go into certain bleeding conditions called DIC, disseminated intravascular coagulation. Especially when patients with abruption, they are not attended to immediately. There can be consumption of all their coagulation factors happening in the body, due to which they bleed more from all sides. So that is actually called as DIC. They can actually go into renal shutdown or renal failure, and need for blood transfusion. So we have to deliver her immediately, and sometimes even she needs an ICU care also. So because of all these, sometimes so when such a thing happens, like she throwing a fit, or she landing in abruption, or she going into DIC, irrespective of the period of gestation, we need to deliver her. We need to terminate the pregnancy. And this puts the baby at risk. Sometimes, of course, unfortunately, there can be an intrauterine fetal death, but if not, a preterm intervention, premature intervention, so due to which, it can result in a preterm low birth weight baby being born. So again, stay in the NICU, and that can actually lead to, neonatal morbidity, mortality, and all that. So we are concerned about all these risks. That's why it's a very important topic today. And, control of blood pressure is very, very important from the beginning. So coming to the topic, so how do we actually tackle a case of high blood pressure? So when you actually see high blood pressure reading for your patient, so supposing she's a booked patient with you, she has been coming to you from the beginning of pregnancy, from the time she knows that she's pregnant. Blood pressure readings have always been normal. It's only after 20 weeks that you see her blood pressure readings going high. So you know that it's a case of hypertension specific to pregnancy. So depending on the blood pressure loss, the protein loss in the urine, you can actually classify her into a case of gestational hypertension or into preeclampsia. The other entity is where she knows she's a hypertension. She herself would reveal the history to you in the first visit. Or you have another set of patients where they are known hypertensives, say from 6 months or 1 year prior to pregnancy, but because they didn't have any symptoms, they don't know. But you know that from your first visit, so you classify them as a case of chronic hypertension. So how do you manage such a case? So there are some investigations. It's not just, the high blood pressure, but yes, in addition to that, as I told you, the complete profile needs to be done, where of course we check for the protein loss. In addition, the complete blood picture, we have to look, into the platelet count. Then we have to check her coagulation profile with, the prothrombin time, INR, APTT, and we need to look into her liver function test, her renal function test, including electrolytes. And the renal function test, especially urea, creatinine, uric acid, has a lot of significance in cases of high blood pressure. And a certain where we are suspecting, a case of autoimmune conditions, we have to check for the respective antibodies. And her detailed thyroid profile also has to be done, because even thyroid disorders have been known to, increase the risk of her developing high blood pressure during pregnancies. And a complete cardiac evaluation, complete renal evaluation. So whenever there is a medical condition that has predisposed to this, so we always better take a physician's opinion, because see, if she's a chronic hypertensive, we have to involve either a nephrologist or a cardiologist or a physician, depending on what the reason for her to develop hypertension is. And another specific interest for us is not all medications are safe during pregnancy. So, the medication that she might be taking till now when she is not pregnant might have to be changed. So we have to give her a safer group of antihypertensive drugs during pregnancy. And sometimes, the dosage of medicine needs to be adjusted. So what she's taking might not be enough. So the dosage needs to be increased. So all this better to be done as a multidisciplinary, teamwork. So we involve a physician and even the concerned, super specialty consultant also. And the same thing, like supposing she's a case of gestational hypertension or preeclampsia, yes, once we confirm the diagnosis, we do start her off on medications, and we have to involve a physician, and then we have to do the complete PIH profile, we say, and we have to keep monitoring it frequently. It's not that, she's 24 weeks now, we have done the profile, we have started her off on medications. So she should be managed more carefully, more closely when compared to an uncomplicated primigravida or a multi woman. So she needs to come for more frequent checkups, and we also have to emphasize her the importance on healthy lifestyle. So she has to restrict salt intake at home. So she has to take a healthy diet. So let her cut down on the carbohydrate intake and the fat intake, and even restrict the intake of salt, because as all of us know, salt can actually retain water. So that can actually again increase her blood pressure. And she needs to have, it's not just that when she comes for her visits to hospital, but always better to monitor blood pressure closely at home. And in spite of the medication, whatever is being given, if the blood pressure readings are not coming under control, she has to visit us and even the physician more frequently. And the dosage of the medication needs to be changed. Or sometimes we might have to add another medication. It's not that only one medication. Sometimes we might have to add a couple of medications during pregnancy. So all this needs to be done depending on what period she has actually developed the high blood pressure. And apart from this, yes, we also have to monitor the fetus very closely. So she'll be needing more scans also. Like, see, the initial scans, okay, the early pregnancy scan, the NT scan at around 12 weeks, and the anomaly scan and all are fine. But we have to check for the Dopplers more frequently. We have to look into the growth parameters more frequently. Like, so say on an average for a normal uncomplicated pregnancy where we do about 2 growth scans, one normally around 28 weeks and other around 36 weeks. But for a case of gestational hypertension or pre-eclampsia, she needs more frequent monitoring, especially where we see that the blood pressure is not under control, or the baby is going into growth restriction side, or already there are some Doppler abnormalities which have set in. Yes, she needs more frequent scans, maybe even once in 4 weeks to 2 weeks to every week. And sometimes we have to check the Dopplers and the amniotic fluid also more frequently. So what happens in extreme cases, when the blood pressure is not under control, and we are dealing with something happening very preterm. So we have to look into the birth weight, the growth parameters more closely, and there can even be a decrease in the amniotic fluid volume in such cases. Because as I told you, everything is to do with the placenta and the circulation. So everything, the programming has to happen at the time of conception itself. When it doesn't happen in the right way, a lot of pro-inflammatory and angiogenic cytokines being released by the body, which causes a lot of vascular changes, and that leads to actually developing pre-eclampsia or gestational hypertension. So that is the reason the perfusion, so nutrition and oxygen supply to the baby might not be appropriate. So that actually results in a preterm baby, or a low birth weight baby, or abnormal Dopplers. So we need to monitor such pregnancies very carefully. And another thing is where we are anticipating early delivery. So like, see, when normally we are dealing with a case of hypertension, be it whatever category out of the three that I told you, we usually try to plan delivery after 37 completed weeks. So whatever due date we give, like whatever the expected date of delivery, there is completion of 40 weeks. But then it doesn't mean that all women deliver exactly at 40 weeks, especially when there are certain known medical issues, because even 37 completed weeks is term, and sometimes there can be some drastic placental changes and placental hypoxia happening after 37 weeks, which sometimes even the scan or the non-stress test that we do periodically might not be able to pick up. So usually we plan delivery after 37 completed weeks. But where the blood pressure is not coming under control in spite of taking 2 medications, that is 2 antihypertensive drugs, 2 separate antihypertensive drugs started, but still the blood pressure is not coming under control, then we have to deliver her probably even after 34 completed weeks also. So it's basically an individualized approach. It's not like, you just draw a line saying I will not do anything till 34 or 37 weeks. It actually varies patient to patient. So it depends on, how her blood pressure readings are, and how much medication she's actually needing. And sometimes there is something called, imminent eclampsia, where in spite of the medications, the blood pressure is not coming under control. And, she might develop some imminent symptoms and signs. Like, she might have headache or blurring of vision or pain in her upper abdomen. She might have vomitings, and, her urine output might be decreased, or her blood parameters might not be promising. So this is called imminent eclampsia. And then suddenly she might throw a fit. As I told you, it's called eclampsia, or she might land in abruption. Of course, there are certain, some warning symptoms or warning signs which do tell us that, this woman is more at risk for those. But many a times, we have cases unexpectedly just with mild, preeclampsia or mild pregnancy-induced hypertension on medication, still can land in abruption, or, can throw a fit and land in eclampsia. So those cases, as I told you, irrespective of how many ever weeks, let it be 28 weeks, 30 weeks, whatever, explain the prognosis, because mother's life here is more important, and then we have to deliver her, we have to terminate the pregnancy. But if not, like, if all the blood parameters are, fine, and especially when she's a case of severe hypertension and then on 2 medications, we try to actually go beyond 34 weeks, because that is actually a milestone based on, baby's lung maturity. And for the other mild cases without any imminent symptoms, all blood parameters doing fine, we try to prolong till 37 completed weeks at least, so that, we have a term baby in front of us. So for cases that give us time, better always to give steroids to the mother, and that is mainly to enhance the lung maturity, because we are not going till 40 completed weeks for such women. And sometimes, even delivery at 37, 38 weeks, the lungs might be a little bit immature, and more so it happens before 37 completed weeks. So always better to give steroids. So they are given in 24 hours apart, two ways of giving steroids. The main advantage is it improves the lung maturity of the baby. So where we are anticipating a preterm delivery, it will actually help in improving the lung maturity, so that that will reduce the neonatal stay and neonatal morbidity for that particular neonate. But of course, cases without any warning coming to you directly in eclampsia, abruption, or DIC, there is no time for steroid. So whatever be the condition, explain it to the patient and to the attendants, and then we have to deliver her. And there are certain complications, like even during delivery. It's not that just because we have planned everything would be fine. And let me tell you one thing. So basically here, especially when we are dealing with mild cases, and we are planning for delivery after 37 completed weeks, we can actually go for an induction of labor, because cesarean section is only for obstetric indications. So high blood pressure per se doesn't really put her as a in the category where she needs a cesarean section directly. Of course, where she has not progressed, the induction of failure of labor has failed or not progressed, only in those cases. So mainly it's only for obstetric indications. But for other cases like eclampsia, or abruption, or DIC, very unfavorable cervix, not in labor, then there is no option. We have to deliver her by cesarean section. But these category of patients, again, as I told you, even during labor she can throw a fit. That's a very well-known entity. It's called as intrapartum eclampsia. Or even during labor, actually, the blood parameters might worsen, and we might be needing blood and blood product transfusion, especially for cases of abruption and DIC. And even we need a trained anesthesia team and a pediatric team available, and the blood bank facilities, because blood and blood product transfusion, sometimes we might be needing many of them. And because the chance of bleeding is more, so during labor, even after labor, it can happen even in normal deliveries, even in cesareans, especially when we're dealing with a case of severe blood pressure, high blood pressure with abruption or DIC. So now when we deliver her, so the job doesn't end here. Okay, so even postpartum, she's at a risk for certain conditions. As I told you, again, there is something called postpartum eclampsia, where she can throw a fit even in the postnatal period also. So blood pressure needs to be very carefully monitored even in the postnatal period also. And especially, cases who have landed in abruption, DIC, yes, they might be needing an ICU care, and the all her vital parameters. So her, respiratory rate, pulse rate, blood pressure, and signs of pallor, urine output. Okay, so all these things need to be checked. And in cases like who have thrown a fit, or cases with imminent eclampsia, we give another medication called magnesium sulfate. So even these women need to be monitored very carefully. And even the medication. So depending on the blood pressure readings, the medicine needs to be tapered, or the medicine needs to be changed, or some other medication needs to be added. So we cannot just abruptly stop whatever medication she has been taking during pregnancy. So we might have to involve our critical care team, physician, even in the postnatal period also, because she's a high risk patient even after the delivery. So it's not that whether it is cesarean or normal delivery, so the baby is out and the job is done. It's not like that. So because see, as I told you, the patients with the first category, that is chronic hypertension, they continue to be hypertensive even after delivery also. So blood pressure needs to be monitored carefully. All her blood parameters need to be monitored carefully, and the medication needs to be continued. So whatever is safe for her, safe while breastfeeding, needs to be continued. Now for the second category, that is gestational hypertension or patients with pre-eclampsia. So these are also the women where immediately after delivery we cannot just stop the medication. So we have to monitor her blood pressure periodically, probably every hour or 2 hours, depending on how severe it was during pregnancy. And depending on that, we decide whether to taper the dose of medication, or in very mild cases to stop it and then monitor her blood pressure, or to continue the blood pressure medications for quite some time. Because let me tell you, it's not that even though it has developed during pregnancy, not all cases of high blood pressure just disappear after delivery. Yes, majority do go off, but there is again a subcategory which continues even after delivery. In that, again, some people they take some time. It might continue for a few weeks to months, and then gradually it might just go away. But for the other category, they actually become chronic hypertensives. So we have to monitor blood pressure while in the hospital and even at home also, and even talk to them about the healthy lifestyle even after delivery. And even if the blood pressure has come back to normal, complete normal after delivery, we have to counsel them regarding proper spacing, contraception for the next pregnancy, because, proper spacing, let her recover at least 2 to 3 years gap before they plan the next pregnancy. So usage of proper contraception needs to be told to her. And the risk of recurrence in subsequent pregnancies also needs to be explained. Because as I told you initially, if she was a hypertensive in her previous pregnancy, that itself puts her at a high risk of developing high blood pressure. She might not be having high blood pressure in between the pregnancies, but she is at a risk of developing high blood pressure during this pregnancy. So we have to monitor the blood pressure carefully while during her 3 days stay in the hospital after delivery, but even after going home, and then when she comes back for a review and a suitable medication. And even if the medication needs to be stopped, it has to be tapered. And even after tapering and stopping it, at least once in a while she has to check her blood pressure to make sure that it is normal. And we also have to stress, as I told you, on proper contraceptive, because especially in our population, in our setup, always better to give them good contraceptive advice, and make sure proper evaluation is done before she gets pregnant again. Okay, so this is what I had to tell you. So do I have any questions to discuss? Yes, so can it cause edema also? Yes. So edema is not compulsory that it is only because of high blood pressure, but yes, edema is a symptom of high blood pressure. It can be even physiological edema also. Because of the growing uterus, as the uterus increases in size, there is a lot of pressure, on the veins, and lot of stagnant, lymphatic drainage and the venous drainage. So that itself can actually cause edema. And yes, edema can be a starting symptom of developing high blood pressure also. So we do check for it in every visit. So yeah, white discharge during pregnancy is again not related to my topic here, but yeah, because it is raised, let me just address it. So see, the moment people see white discharge from the vagina, no need to get frightened, because vagina is full of glands, and they do have their secretions, and that is what we actually call it as white discharge. Now, because all those glands hypertrophy, they increase in size, and they are more active. Yes, you do find more white discharge in pregnancy. But so the moment you see some watery or milky white discharge, you don't have to get worried about. But still, if it is concerning you, always get yourself examined. But where it is thick, curdy white, or cheesy white flakes, or creamy, greenish yellow, associated with foul smell, itching, that is what mostly suggests infection. So yes, whenever you feel it is more than normal, always get yourself examined, by a doctor, and she would clear your doubt. Thank you. So yeah, any more doubts? I think if there are no doubts, I can probably conclude this session, I think. Yeah, thank you then.